Let's sprint through syncope. Syncope is a brief, self-limited loss of consciousness due to transient cerebral hypoperfusion, with loss of postural tone and rapid, complete recovery. If the patient stays confused for a long time, we're probably not dealing with syncope. Here's the big picture. There are 3 buckets you should keep in mind: reflex syncope, or also known as vasovagal and situational syncope, orthostatic syncope, and cardiac syncope. Cardiac is a dangerous one, as the 1-year sudden cardiac death risk can approach 40% in patients with cardiac syncope. So in the management of a syncope case, our triage brain always asks, is this cardiac? Before we dive into causes, let's clear the most common confusion: syncope versus seizure. Seizures often have an aura, strange smell, visual change, or sometimes no warning at all. Tongue biting is common and classically lateral. Convulsive movements happen before or with loss of consciousness. Urinary incontinence is common, and the postictal phase has lingering confusion that can last minutes to hours. Syncope can have a prodrome: nausea, warmth, pallor, diaphoresis, lightheadedness, but recovery is rapid, usually within 1 to 2 minutes, and there's no residual deficit. Tongue biting is rare. If present, think frontal tip rather than lateral. And yes, brief myoclonic jerks can happen after loss of consciousness, and syncope, transient hypoxia can do that. So don't let a bystander's "they shook a little" automatically push you into seizure. Now, how do we sniff out the cause from the story? Clues matter. A prodrome: nausea, sweating, warmth, points toward vasovagal. Normal orthostatics argue against orthostatic hypotension. No warning, especially with exertion or in a patient with structural heart disease, points to cardiac. That's the triage logic. Let's start with reflex syncope. This is your classic vasovagal episode, and it's the most common, especially in younger patients. Triggers include pain, emotional stress, heat, crowded spaces, prolonged standing, think graduation ceremonies or long queues. Situational reflex syncope is the same physiology with a specific trigger: micturition, defecation, swallowing, cough, even hair combing. What's happening physiologically? Either a sudden surge in parasympathetic tone, leading to a cardioinhibitory response, bradycardia or even sinus arrest, or a drop in sympathetic tone causing vasodilation and an abrupt blood pressure fall. Either way, cerebral perfusion dips and they go down. The story gives it away: prodrome of warmth, pallor, nausea, diaphoresis, maybe my hearing tunneled, then a brief loss of consciousness and a quick recovery. Most cases are clinical diagnoses. If uncertain, a tilt table test can reproduce it. Management here is simple and very step 2. Reassure. Avoid triggers. Teach patients to lie supine with legs raised at the first hint of prodrome. For frequent episodes, teach counterpressure maneuvers. Cross the legs and tense the thighs, clench fists, or do a sustained hand grip. These increase venous return and cardiac output and can abort an episode. If someone's in a high-risk job, pilots, commercial drivers, restrict activities temporarily until they demonstrate control with these maneuvers. Closely related is carotid sinus hypersensitivity, which shows up in older adults, often men with atherosclerosis. Here, even light stimulation of the carotid sinus, tight collars, turning the head while shaving, triggers an exaggerated vagal response, bradycardia and vasodilation, causing a pause of more than 3 seconds and a big drop in systolic pressure, often more than 50 millimeters of mercury. Diagnosis can be confirmed with monitored carotid massage. Avoid if you suspect significant carotid stenosis. Treatment ranges from trigger avoidance to pacing for recurrent, severe cardioinhibitory responses. Next, orthostatic syncope. This is about failing to maintain blood pressure when standing. It's common, often underrecognized, and very testable. 3 big categories cause it. 1. Medications. Vasodilators like alpha, 1 blockers, hydralazine, nitrates, ACE inhibitors and ARBs, dihydropyridine calcium channel blockers, diuretics causing volume loss, beta blockers and clonidine blunting sympathetic compensation, SGLT. 2 inhibitors via osmotic diuresis, and even antihistamines, TCAs, and antipsychotics with alpha blockade. 2. Hypovolemia, GI losses, poor intake, fever. 3. Autonomic dysfunction, think long-standing diabetes or neurodegenerative disease, and advanced age. The presentation is textbook: lightheadedness or visual blurring when rising, maybe a near syncope in the morning. Diagnosis is objective: a drop in systolic BP of at least 20 or diastolic of at least 10 within 2 to 5 minutes of standing from supine. Management: fix the precipitant, slow postural transitions, hold or reduce culprit meds, hydrate and increase salt as appropriate. Compression stockings and abdominal binders help in autonomic failure. Now the high-stakes bucket, cardiac syncope. This is the one you must not miss. Here, there's often no prodrome. The episode may occur during exertion or suddenly while sitting quietly. Patients might report palpitations just before collapse, but nausea and sweaty prodrome aren't typical. There are a few classic subtypes. First, left ventricular outflow obstruction, either aortic stenosis or hypertrophic cardiomyopathy. Exertional syncope is the red flag. On exam, you'll hear a systolic ejection murmur. For aortic stenosis, expect a crescendo-decrescendo murmur at the right second intercostal space radiating to the carotids, delayed upstroke, pulsus parvis et tardis, soft or single S2, and maybe an S4. In HCM, the murmur increases with Valsalva or standing and decreases with squatting. Second, ventricular tachycardia. This often has no warning. Look for a history of ischemic heart disease or cardiomyopathy for monomorphic VT, or prolonged QT for polymorphic VT and torsades. Sudden collapse in a patient with a recent MI, VT until proven otherwise. Third, conduction disease, sick sinus syndrome and advanced AV block. Patients describe preceding fatigue or lightheadedness, maybe exercise intolerance. On ECG, look for sinus pauses, prolonged PR intervals, bifascicular block, or dropped QRS complexes. One key teaching point: a normal heart rate at a single time point doesn't exclude bradyarrhythmia. AV block can be intermittent. A few high-yield reminders. Third-degree AV block usually happens in patients with cardiac history, prior MI, infiltrative disease like amyloidosis or Lyme carditis, atrial arrhythmias with very rapid ventricular response, AF or flutter above 150, can also cause syncope because diastolic filling collapses. And sinus tachycardia by itself does not cause syncope, it's often a reflex after the episode. Diagnostics should follow the story. Start with a 12-lead ECG on everyone. If you suspect arrhythmia but it's intermittent, use ambulatory monitoring, Holter for frequent events or event recorders / implantable loop recorders for sporadic ones. If the exam or ECG suggests structural disease, get an echocardiogram. If exertional symptoms or ischemia are suspected, do a stress test. If the story screams reflex syncope but you want proof, consider tilt table testing. The goal is targeted testing, not a fishing expedition. Treatment is tailored to cause. Beta blockers are useful when the problem is rate control for certain tachyarrhythmias or in HCM, pacing for significant bradyarrhythmias or cardioinhibitory carotid hypersensitivity, valve intervention for severe aortic stenosis, hydration and med adjustments for orthostatic, education and counterpressure for vasovagal. Let's cement reflex syncope with a quick case. A healthy 22-year-old faints while standing in a hot, crowded hall. She felt warm and nauseous with dimming vision, then slumped, regained consciousness within a minute, and was normal in 2 minutes. Normal vitals and exam now. That's vasovagal. Teach her to lie down with legs up at the first hint of prodrome, hydrate, salt as needed, and try leg crossing and hand grip if warning symptoms recur. Another case. A 68-year-old man faints while shaving. His wife says he looks pale and drops suddenly for a few seconds. He's on antihypertensives and has carotid bruits. That's carotid sinus hypersensitivity. Avoid tight collars and neck pressure. Evaluate carefully before any carotid massage, pacing if recurrent and cardioinhibitory. Now a cardiac red flag case. A 72-year-old with exertional chest tightness passes out while climbing stairs. On exam, there's a harsh late-peaking systolic murmur at the right upper sternal border that radiates to the carotids, delayed carotid upstrokes, and a soft S2. That's severe aortic stenosis. He needs echo and valve replacement planning. Medical therapy won't fix the obstruction. Medication-induced orthostasis, another classic. A 58-year-old started taurusin for BPH and now gets dizzy when standing. Orthostatics are positive. Hold the alpha blocker. Adjust other vasodilators or diuretics. Educate on rising slowly and rehydrate. 2 special lookalikes you should name on test day. Psychogenic pseudosyncope, apparent transient loss of consciousness without impaired perfusion. Episodes last many minutes to hours. Patients remain physiologically normal during the event. No pallor, no diaphoresis, normal vitals, and they can often report what happened during the unconscious period with a detached effect. High episode frequency, often daily, and a psychiatric history are common. Management is psychiatric, not cardiology. And cataplexy, emotion-triggered loss of muscle tone in narcolepsy, can look like syncope but is very brief and occurs in the context of excessive daytime sleepiness and other narcolepsy features. Let's wrap with a quick, exam-ready checklist. 1. Decide dangerous or not in the first minute. Exertional syncope, no prodrome. Structural heart disease, abnormal ECG, these are cardiac until proven otherwise. 2. Reflex syncope has a prodrome and a trigger, teach counterpressure maneuvers and supine positioning. 3. Orthostatic syncope needs orthostatic vitals, a med review, and volume assessment. Fix the culprit meds and fluids. 4. ECG for everyone. Echo if structural disease is suspected, ambulatory monitoring if you think arrhythmia, tilt table if the story is reflex but you need confirmation. 5. Treat the cause. Pace the bradycardic, replace the valve, beta block the HCM or certain tachyarrhythmias, hydrate the orthostatic, and counsel the vasovagal. That's syncope. Physiology first, pattern recognition second, and targeted diagnostics. Keep that framework in your head, and you'll crush these questions on Step 2 CK and nail it on the wards.